Hello and welcome. My name is Gerhard Hindricks from the German Heart Center of the Charité in Berlin, and I'm happy to welcome all of you for an update on sudden cardiac death, risk prevention, on the latest of scientific activities, clinical importance, and our attempts to improve outcome. I have the privilege to have two experts, internationally well-renowned, at my side that will help us to better understand sudden cardiac death and help us to find ways to pave to better medical treatment in the prevention of sudden cardiac death. And I warmly welcome Professor Helmut Pürerfellner from Linz in Austria, current president of European Heart Rhythm Association. A privilege to have you here, Helmut. And of course, Nikolaus Dagres from the German Heart Center of the Charité in Berlin. Nikos, welcome. It's a privilege to have you here at the site as well. Helmut, what is the role of sudden cardiac death in 2025? Is it still a relevant element and issue? How would you quote on that?
Yeah, thanks, Gerd. Of course, it's a relevant issue. Thousands and hundreds of thousands of people die because of sudden cardiac death. And not only have sudden cardiac death, but also die. That means that resuscitation still has low success rates. So many thousands of people do not make it to the hospital. So it's still a major problem, and we did not make huge progress on that. What we did and what we have done is that we have better therapies for heart failure. And so the rate of sudden cardiac death has decreased, but it's still a major problem across the world.
So primary prevention because of sudden cardiac death remains one of the key challenges. Do we have any advantages made in identifying patients that are at specific risk, and what would be a timely approach to protect them?
This is a very important question, Gerd. So sudden cardiac death, as Helmut explained, is a very relevant problem. It's actually the leading cause of death. So it's the major challenge for us to solve in the next years. The problem is that we did not find a way to effectively identify the patients who are at high risk for sudden cardiac death. Lots of scientific efforts, lots of different reports describing some markers, but not a strategy that can really bring us forward in that field.
There is a huge project currently ongoing, financially sponsored by the European Commission under the umbrella of Horizon 2020, the Profit Era project. Can you line out for us what Profit Era is about? What are the key elements and what are the key goals in the field of sudden cardiac death?
Well, to start with, to have a prophylactic ICD implant in a patient post-MI below 35% of ejection fraction is currently a class 1. But the data that we have to have it as a class 1 is based on data that have been published 20 years ago. So all the drugs, these Fab4 drugs that we have now, have not been on board on these patients. So the problem is that we see on the one hand that sudden cardiac death and especially arrhythmic death decreases in those studies. However, the complication rate of the devices that we have are still quite high. So there is a kind of imbalance now, and we are asking the question, is it still justified to have a primary prophylactic ICD? And so we thought about the best protocol to get this done, this study done, which of course then challenges a class 1 indication. So that's very special, I think, in this study, makes it so special for us also to be in. And we take patients who are 3 months after the myocardial infarction at least, are on optimal guideline-directed medical therapy, have an ejection fraction below 35, and are in class 2 and 3. And these patients are then randomized in a one-to-one controlled fashion to either ICD, which is the control group. It's not the active group, it's the control group. And the active group is the group with optimized medical therapy alone.
So the key messages from what you were saying is the data that we have from trials that have been published are outdated. We cannot use them anymore. We need fresh data to re-evaluate the role of the ICD in primary prevention post-myocardial infarction.
Exactly.
Nikos, you have been one of the big promoters of the Profit ERA project, and the step one of the project, the re-evaluation of existing evidences on risk stratification, has been recently published in the European Heart Journal, a remarkable piece of science, very, very important for the further course of the study. Can you summarize for us the key elements that you found out this remarkable analysis?
With pleasure, Gerd, and it was indeed a pleasure to do it together with you and all our partners. The first part of Profit indeed was focused on trying to see who is at risk, which patients are the ones who are at risk, and that should be protected by implantation of the device. So we analyzed data from more than 20 data sets and 200,000 patients post-myocardial infarction to identify patients with high risk across all different left ventricular ejection fraction groups. And I think we can summarize that we found that an accurate risk prediction was not feasible. So we looked at all different risk stratification markers that have been reported previously, and there was none that could really help us identify high-risk patients and low-risk patients, which led me ask the question, is it predictable? Is sudden cardiac death a predictable event? This is an open question for me.
Helmut, the European Heart Rhythm Association, and you are here as the president of the association, is also deeply involved in the project. Why do you think ERA is such a strong promoter of the project? Is it because of the importance of sudden cardiac death? Why do you go so intensely into that topic?
Because we see this imbalance. We see the clinical need of the study. We see that we have a lot of patients who receive a device who do not need it. And we see that they have complications over the years. So the complication rates of the devices is around 10%, even more, over a span of the life of the ICD. So that makes us think, how can we do better? And of course, this is also one of the beauties of a heart rhythm association, to care for the patients, to care for the ones that are the ones that we have to treat. And so that's only natural, I would say.
To promote patient values,
Sure.
and to work on a better quality of care. And the trial has already started. Can you summarize for us where the Profit ERA trial currently stands?
Well, we are more or less at the start. We have had around 250 implants, very interesting in patient population, with 70% class 2, around 30% class 3. So we are at the start. We need more implants. We need still more patients, because the study is designed to have around 3,500 patients to be enrolled in order to get an event rate that will then show a benefit or not.
Which is the biggest ICD trial that has ever been conducted on the planet.
So it's
Awesome.
such a project that needs all our energy, all our enthusiasm,
passion.
and all our passion in order to make it go, because it's an effort. It's an effort. But we have a lot of centers now, so the research organizations are really supportive for that. We have 70 centers now that are already starting to include the patients, but it still needs an effort. It still needs some additional centers and a lot of patients.
It's a challenging project, and it needs a lot of energy to promote that, but I think everybody involved, and with the support of European Heart Rhythm Association and the ESC, it will be doable and it will be successful.
Yes, I'm really optimistic about that, and I'm enthusiastic about it. And it's a privilege to be in such a study, to be honest. There is not many studies in your life, my life, where you have been on such a question.
I couldn't agree more. it's a huge privilege to be part of this project that aims on the improvement of quality of care for the people in Europe with a global perspective. Nikos, we are currently here in Madrid at the marvelous ESC 2025 meeting, and there have been very, very interesting data presented yesterday on a trial called
Refine ICD.
Refine ICD. Can you summarize the key structure and the key outcomes of Refine ICD, and then give us a perspective on the impact of the results for Profit-ERA?
With great pleasure, because Refine ICD fits, the results of Refine ICD fit extremely well with what we have reported from the first part of the Profit project, and confirm with great emphasis the need to conclude successfully the Profit-ERA trial. Refine ICD was a trial focusing on the population with an ejection fraction above 35% up to 50%, and recruited patients that were deemed to be high risk based on heart rate turbulence and T-wave alternance. So a way to risk stratify the patients and to take those who were considered to be at high risk for sudden cardiac death. Patients were randomized to ICD plus optimal medical treatment versus optimal medical treatment, and with a primary endpoint of total mortality, which is the same as in the Profit-ERA trial. It took 14 years to conclude, so this shows the difficulties in recruitment in these trials, how challenging it is. 600 patients approximately, and it was a neutral trial at the end, so no survival benefit for the patients who were treated with the ICD. And this is very, this confirming the Profit results in the sense that the mortality rates were very low in that patient segment, and because it shows the need to look also at the segment of patients with ejection fraction below 35, which is exactly what the Profit-ERA trial is doing.
So basically, Profit-ERA is the reasonable next step after the Refine ICD results that have been published yesterday. Helmut, are there any other important items going on in the field of risk stratification that you consider important if we look to MRI imaging, genetics?
Sure. I think that's what we have in the trial. So I'm very happy about it. What Nikos says is exactly on my line. I think with demographic variables, it's hard to predict the future. And risk prediction, somebody has said risk prediction is hard, especially if it relates to the future. But that is a risk prediction. It relates to the future. And I think by just demographic variables, age, ventricular function, whatever, I think it's pretty hard. So we need more. And I think artificial intelligence is a way to get it better. And we will have AI in the study, in sub-studies relating to the ECG, analysis of the ECGs with people with having events and without events. We are having a genetic sub-study, and we will have a study on MRI plus AI work done over this in order to get a better feeling of how we can predict. And I'm pretty sure that without these new technologies, without generative artificial intelligence, we will not make it.
Yeah. So we will have it all in the upcoming Profit-ERA trial, genetics, AI for ECG analysis, AI for imaging, and a specific CMR sub-study. Nikos, what are the timelines that you project for the clinical trial? What's realistic?
Difficult to say, Gerd. Surely the Refine ICD shows how difficult it is, confirms what we saw in Danish, many years of recruitment, so several years. And of course we need the contribution of every center, of all physicians, of all the community, to conclude it successfully.
Yeah. Support is important. That's why we are here, to communicate into our communities the importance of further data on risk stratification, and prevention of sudden cardiac death, particularly following myocardial infarction. Thank you, Helmut Pürerfellner.
Let me announce a meeting. We have a meeting.
Very important point, Helmut.
Let me announce that. We have a meeting on update on sudden cardiac death. I think we have a very nice panel. And we are doing it together, us three. Maybe you can comment on
And
that.
we do it in Berlin.
And we do it in Berlin. And so we do it in 28, 29 in November in Berlin. And I think it will be a splendid meeting there and a nice update on sudden cardiac death.
That was important information. And I'm really happy to welcome the two of you, as well as many, many other colleagues from the community, end of November in Berlin, to get an update on sudden cardiac death. We got an update on sudden cardiac death with the expertise of the two of you. We are grateful that you shared this time with us here today. Thank you very much for coming and informing our communities on the importance of sudden cardiac death and new strategies to improve treatment. I hope that you enjoyed this interview, and thank you very much for your attention.